Hello.
Hello.
Yeah.
Yes. Good
Nice.
morning. Today we will have a series of faculty lectures. These are the lectures we chosen from recent advance in surgery. Dr. P.K. Bhattacharjee, who is a professor of surgery at Arjigad Medical College, will deliver the today's faculty lecture on Paraisophysial Hernia. Dr. Bhattacharjee, you can start, please.
Okay. Good morning. Good morning, everybody. Now, a patient with Paraisophageal hernia may present to a clinician with a history or with a presentation somewhat like this. The patient may be usually an obese female in a 6th or 7th decade who presents with a significant history of heartburn or spontaneous regurgitation for last few months, which is controlled by PPI only, taken daily. That is the typical symptoms of GERD. More recently, she may be experiencing mild postprandial chest discomfort, early satiety, and there may be history of loss of weight. Other significant points in the history may be dysphagia, vomiting, and sometimes the patient will say that loud belching sort of relieves her discomfort. On examination, she may be otherwise normal. No lymphadenopathy, abdomen may be soft, is usually soft, without any obvious tenderness or palpable masses. Heart sounds are normal. Her lungs, both vesicular breath sounds on either side. And on auscultation of the chest, you might get bowel sounds from within the chest. A laboratory investigation might show a little bit of low hemoglobin level, and chest X-ray might reveal, a gas-filled loop of intestine within the chest, paracardiac region, in the region of the heart shadow. And obviously, with these symptoms, you'll be asking the patient to undergo an upper GI endoscopy, and the endoscopy might show finding like this, where the retroverted the endoscope will show the hernial orifice through which the portion of the stomach has herniated within the chest, and there will be twisting of the gastric mucous membrane, as can be seen here. Okay, these are the typical findings, and sometimes it may be very difficult to orient oneself within the stomach because of the rotation, the volvulus of the organs concerned, mostly the stomach in this case. Now, this paraesophageal hernia usually occurs through the esophageal hiatus, as can be seen in this particular diagram. This is the obviously the picture of the diaphragm, which has got a central tendinous part and a peripheral muscular part. The muscle fibers are attached anteriorly to the xiphoids, laterally to the rib cages, and posteriorly to the vertebral column. The esophageal hiatus is basically formed by the, as you can see from this picture, that it is basically formed by the split right crust. Though we say when we repair the crust that we repair the right and the left crust, actually this the esophageal hiatus is formed by the splitting of the right crust itself. The left crust can be, as can be seen in this picture, is separate from the esophageal hiatus. So basically, there are two pillars of the esophageal hiatus. Two pillars of the esophageal hiatus. One is the right pillar, and other is the left hiatal pillar. The esophageal hiatus is located at T10 level. The other hiatus that can be seen here is the vena cava hiatus above, usually the T at the level of 8th thoracic vertebra, and the another one is the aortic hiatus below, which is bounded by the median arcuate ligament, and that is at the level of the T12 vertebra. Now, the esophagus, the adventitia of the esophagus is attached to the crura by what is called a phrenoesophageal ligament, which is basically a fusion of the endoabdominal fascia and the fascia transversalis. And two important points to note here is that when you repair the crura, the aorta comes in very close contact, and one must be very careful not to prick the aorta here. And another is the crural vessels may be lying usually along the left pillar of the right crust. The crural vessel may be the branch of the phrenic artery, may be running parallel to that, and you must be careful about that vessel also while you repair the crura. Otherwise, there might be troublesome bleeding. The other structure, that important structure which passes through the esophageal hiatus, is of course the vagus nerve. The aortic hiatus also permits the passage of the thoracic duct and the esophageal vein along with the aorta, of course. Now, if you go to the epidemiology, the paraesophageal hernias, which are also called the rolling hernias, are an uncommon variety of the hiatus hernia. The commonest type is the sliding hernia, which constitutes around 90 to 95% of the cases. Paraesophageal hernia is around just about 5 to 10% of all hiatus hernia. They are more common in the elderly female in the 6th-7th decade. The predisposing factors are reflux. The long continued reflux causes basically the fibrosis, repeated esophagitis, and stricture and shortening of the esophagus, leading to pulling up of the esophagus as well as the adjoining stomach within the thorax. So long continued, long history of reflux, increased intra-abdominal pressure like chronic cough, chronic constipation, pregnancy, or heavy manual labor, defective collagen synthesis, as in the case of common inguinal hernia, has also been implicated as one of the causes of development of hiatus hernia. Patients with kyphosis have been found to be particularly predisposed to develop hiatus hernia. Most of the cases of the hiatus hernias are asymptomatic, but there can be very serious life-threatening complications like obstruction, acute dilatation, perforation, or bleeding from the gastric mucous membrane, though the percentage of these complications are very low. Now, point to note here is the sliding hernia is the sliding hiatus hernia is similar to the sliding hernia that we commonly see in the groin, in the sense that it is basically a retroperitoneal slide. The anterior layer of the esophagus, just like, for example, the cecum, in case of a sliding hernia, a sliding inguinal hernia, is covered by the peritoneum. Here, the anterior layer of the anterior surface of the esophagus is covered, has a peritoneal lining. The rest of the things are all retroperitoneal. It's basically a retroperitoneal slide. On the other hand, a paraesophageal hernia would have a definite hernial sac, is a peritoneal layer that forms a true hernial sac, and it distinguishes it from the much more common sliding hernia. The paraesophageal hernias may be of basically 3 types. The type 2, so-called the type 1, is the sliding hiatus hernia. Type 2 is where the gastroesophageal junction remains in the abdomen, and the stomach rolls up by the side, that is paraesophageal position. The most common type is a mixed type, where there is a combination of the sliding hernia plus the type 2 hernia or the rolling hernia. That is, the gastroesophageal junction is pulled up within the thorax, as well as some portion of the stomach will herniate through the esophageal hiatus within the thoracic cavity. And that is the commonest type of paraesophageal hernia, constituting about 76, almost 80% of the cases. And another rare variety is the combination of not only the sliding hernia, rolling hernia, but along with that some other extra gastric portions of the abdominal viscera will also herniate, like small bowel, colon, even spleen can herniate into the thoracic cavity within that peritoneal sac that is formed in this case. Now, there is this hernia, just like again the groin hernia, runs the risk of some very serious complications, as we have just mentioned in the other slide. mostly because of the volvulus that takes place. This rotation of the stomach usually can take place along the axis of the stomach, that is called organoaxial, or along the across the axis of the mesentery. The mesentery gets twisted, which is the second variety is much more dangerous because it can lead to strangulation of the content, the stomach, and this portion of the stomach which herniates inside, and leading to gangrene and perforation of the gut and carries very high mortality. Now, presentation, it may be just an incidental presentation, as most of this, as we mentioned, in most of the cases asymptomatic. Patient undergoes a chest X-ray for some other reason, and you can detect that a gas-filled loop of intestines within the chest. So that way, that can be picked up incidentally. Symptoms maybe due to twisting or volvulus of the stomach, for example, nausea, vomiting, chest pain, reflux, esophagitis. These are very common in case of rolling type of hernia. Postprandial fullness, early satiety, chest pain, breathlessness, regurgitation, and loud benching, which relieves the symptoms of chest pain and other chest discomfort. So many of these symptoms are like that of symptoms arising from cardiac pathology. So one must be careful to exclude a cardiac pathology in such cases. And some patients will present with extra esophageal symptoms because of repeated aspiration, leading to features of respiratory tract infection, repeated cough, laryngeal irritation. Okay, so occasionally patient may present with anemia because of hematemesis, because of the twisting of the portion of the stomach leads to congestion of the veins in the underneath the mucous membrane, and these can burst open to start the bleeding, and such repeated bleedings, maybe in small amounts, will lead to development of anemia. Another common cause of development of anemia is the Cameron's ulcer, which are basically linear ulcers or erosions that occurs on the mucous folds of the stomach at the level of the diaphragmatic hiatus. So when the endoscopist does an endoscopy by these Valsalva maneuver, they can make the pinching action of the crura prominent, so he can mark out the portions of the crura, and at that particular region you can find these linear ulcers, which are called Cameron ulcer, which can lead to very slow bleeds. These ulcers sometimes spontaneously disappear also, so that can lead to development of anemia. And the most dangerous presentation is, of course, that due to volvulus of the stomach leading to gastric perforation and gangrene, which carries very high morbid mortality. One of the this is an interesting triad of findings, which is called Bhattacharjee triad, that is found in case of gastric volvulus in paraesophageal hernia, where patient will repeatedly retch without any output. There will be no vomiting, but repeated retching. There will be chest pain, and on trying to put the Rice tube, you'll find that after a certain distance, you are unable to push the Rice tube down. So these three forms the Bhattacharjee triad of complicated paraesophageal hernia. The differential diagnosis would include entities like peptic ulcer disease, GRD, the much more common hiatus hernia, of course, the polylithiasis, cardiac disease, as we said, must always be excluded, and other esophageal pathologies like esophagitis and esophageal malignancies. Now, investigations, we had already discussed, told about this particular X-ray here, where you can see gas bubble with a fluid level within the chest, typical of paraesophageal hernia, and or you can find an opacity involving the lower zone of the right lower zone of the chest, which on lateral view will reveal basically air fluid levels, typical again of paraesophageal hernia. The contrast studies will show, basically barium in the fundus of the stomach at the level of the of the thorax, above the diaphragm. Diaphragm, you'll find the portion of the stomach with barium within it, or where in instances where the esophagus has not got shortened, you'll find the herniation of the stomach will make the esophagus somewhat sigmoid-like, distorted. This, in other cases, you will find a paraesophageal hernia where the stomach gets completely twisted upside down, and the pylorus may be just below the level of the hiatus in this case. In this particular diagram, again, another barium-filled stomach, which is basically completely upside down. This is typical of a paraesophageal hernia. By definition, a giant paraesophageal hernia is one where more than 50% of the stomach will be intrathoracic, or the defect in the diaphragm is more than 5 centimeters. Next investigative tool in your hand will be a CT scan, which is often the best method to diagnose and confirm the more serious types of paraesophageal hernia, that is type 4 paraesophageal hernia, which contains not only stomach but adjoining parts of the abdominal viscera. It defines the anatomy, the guides the preoperative planning, especially for large type 3, type 4 hernias, and also gives you an idea as to the size of the defect, the morphology of the defect. This particular coronal cut shows the stomach once again within the thorax, above the level of the diaphragm, turned upside down. The sac can also be seen very well here. And here you can see the stomach lying in a retrocardiac position, the fluid and air-filled stomach lying in the retrocardiac position. Obviously, most of these symptoms are upper GI related. So a very common investigation that we suggest is the upper GI endoscopy. The common findings in case of hiatus hernia will be esophagitis, or evidence of stricture, Barrett's esophagus, or Cameron's ulcer, as we had already discussed. They are small linear ulcers at the level of the hiatus, esophageal hiatus. The location of the gastroesophageal sphincter can also be properly picked up with the help of a upper GI endoscopy. And if you find that the distance between the esophageal hiatus and the squamo-columnar junction of the esophagus is more than 2 centimeters, that will confirm the presence of hiatus hernia. Okay, that is gastric mucous membrane between the hiatus and the squamo-columnar junction of the esophagus is more than 2 centimeters. That confirms the presence of a sliding hiatus hernia. It also differentiates type 2 from type 3 hiatus hernia by noting whether the hiatus, the gastroesophageal junction has its its normal position within the abdomen, or it has slided up within the thorax. The endoscopic appearances may sometimes be confusing, especially for large hernias with upside down stomach, and the endoscopist can very easily become sort of disoriented. The twisted gastric mucous membrane and inability to pass the endoscope into the pylorus, and the defect seen, as we said already, the defect seen by the retroverting the endoscope, the defect seen in the diaphragm through which the stomach will be herniating inside the thorax, can be very well visualized by a retroverted endoscope. So these are the typical findings, where the twisted mucous membrane will be where the volvulus is there, somewhat twisting is there, and the inability to pass the endoscope into the pylorus. That is another typical finding in case of paraesophageal hernias. Endoscopy can also help you in inserting the nasogastric tube where blind insertion is unsuccessful, and endoscope can also help in detorsion of the twisted stomach. But one thing to remember, that while you are rotating the twisted stomach, is patient should have an endotracheal tube in position, because there may be sudden patient can develop aspiration otherwise, because the fluid and food material may be there within the stomach, which may suddenly be pushed within the oral cavity. Manometry is not critical for preoperative diagnosis. This also shows small Cameron ulcers at the level of the esophageal hiatus. The indications of surgery in case of paraesophageal hernia, as we said, most of the cases are asymptomatic, and a selective approach should be taken for those who are asymptomatic, but you have diagnosed them, keeping in mind the potential risks of complications. You can go for a selective wait and watch policy or selective repair in these cases who are asymptomatic. But those who are symptomatic, the type 2 to 5, type 4 should undergo some form of repair. And of course, if the patient presents with an acute complication like obstruction volvulus, it will always require, most of them will require surgery. If not, if not the endoscopist can de-rotate the stomach, of course, that can be postponed a little while. Other most of the cases will require a surgery. The approaches may be open transabdominal, open transthoracic, or a laparoscopic repair. The fundamental steps of paraesophageal hernia repair is, number one, you have to completely reduce the herniated portions of the gut from within the hernial sac back into the abdomen. The stomach and gastroesophageal junction should be pulled down to the abdomen, number one, without much tension. Then you have to completely reduce and excise the hernial sac, the sac that has not only the viscera, you have to also dissect down the hernial sac and excise it. Some cases of esophageal shortening requires a little bit of esophageal mobilization and lengthening. Then this is followed by, of course, approximation of the crura to reduce the size of the defect. The approximation of the crura may be done by simple sutures, or you might have to put in a mesh depending upon the size of the defect. And fixation of the stomach is the final stage, so that the stomach do not once again migrate into the thorax. A fundoplication is a very good means of doing that. And or you can also do a gastropexy, that is a fixation of the stomach with the anterior abdominal wall. That will also prevent not only migration but also rotation, again retwisting of the stomach. So these are the few pictorial depictions of how you do the paraesophageal hernia repair. First step, you have to reduce gently. You have to reduce the herniated content back into the abdomen. The dotted lines are basically the portion of the hernial sac that has gone within the thoracic cavity. The dissection, as you can see, to reduce the hernial sac is kept in between the endothoracic fascia and the visceral peritoneum, that is bluntly dissected and brought down. So this you can see, and you start the dissection from the left to the along the crura, from the left to the right. It is started anterior to the left crus, and then you proceed to the right side. The dissection of the hernia sac begins from within the dissection of the hernial sac begins along the inner border of the crura. So the idea of mentioning this is that you keep a portion of the peritoneal lining covered on the crura, so that your repairs, subsequent repairs, become easy. Otherwise, if you expose the longitudinal muscles of the crura, when you take the bites, the muscles may split. So you try to keep a little layer of peritoneum on the surface of the crura. This particular picture shows the 180-degree dissection completed with the crura, the right and left crus demonstrated, and the esophagus in between. Once the peritoneum has been, the sac has been dissected from the, cut open from the left to the right, as in this shown in this picture, you start taking control of the short gastric vessels, and then the plane of the hernial sac and the crura is developed by blunt dissection. this particular picture shows the posterior aspect of the stomach. Now the part of the hernial sac has already been dissected. We had started with at the very beginning, we had started with the big sac within you can see the dotted line there within the thorax. Gradually, as the dissection is going, the size of the herniated sac is reducing, as you can see. In this particular little bit of the sac is still remaining. Finally, you have to take the stomach to the opposite side and do the posterior gastric dissection. So you separate the attachment of the peritoneum from the posterior aspect of the stomach to complete a 360-degree dissection, and finally you excise the herniated sac from the anterior surface of the stomach. And once the reduction of the reduction is the reduction of the herniated content is complete, and the sac has been completely dissected in a 360-degree all around, then you can excise the sac. And after the sac has been excised, with the help of a sling, you can you can pull rather the esophagus to the left, and the crura can be properly demonstrated. And approximate the crura with a few interrupted sutures. Non-absorbable sutures should be used, preferably linen, silk, that can be used. This is called crurorrhaphy. And if the defect is large, you can reinforce this repair with the help of a U-shaped patch of Prolene mesh. But the problem with this mesh, the different types of mesh can be used. Initially, these synthetic meshes were used, then biological meshes have come up. The synthetic mesh had the complication of erosion within the esophagus and gross fibrosis leading to dysphagia. Biological meshes are better in that sense, but still causes a lot of fibrosis and patients can present with dysphagia at a later date. And finally, the retention of the stomach within the abdomen by a fundoplication and a gastropexy, as that can be seen here, where stomach is fixed up with the anterior abdominal wall. The body of the stomach is fixed up with the anterior abdominal wall by series of sutures. This not only prevents the re-rotation of the stomach, but also somewhat accentuates the angle of his, so that the reflux is minimized. 15% of the giant type 3 hernias have a shortened esophagus because of repeated esophagitis and stricture formation. The esophagus will be shortened, and in these cases requires an elongation of the mobilization and elongation of the esophagus. That can be done if it is not, the dissection itself is not sufficient. You might have to do a surgical maneuver, which is called Colles-Nissen's procedure, where you basically use a stapler to along the angle of his, so that the angle of his is extended a little bit downward. This lengthening procedure for a shortened esophagus, especially for type 3 hernias, is to be considered. Prosthetic meshes are for secure crural repair, but are associated with some rare but serious complications like erosion and fibrosis. Recurrence rate following mesh repair is usually low, around 5% or so. And complications of surgery may be either age-related, because of patients have repeated episodes of these regurgitations, so they're a little bit pulmonary compromise is already there. Some patients may develop atelectasis, pneumonia, DVT, pulmonary embolism, myocardial infarction, or arrhythmias. The dissection of the viscera during the reduction of the hernial content can lead to serosal tear, or sometimes even perforation. Inadvertent injury to the vagus nerve. This vagus nerve needs to be preserved throughout the surgery. You have to try not to injure the vagus nerve, because in case the vagus nerve is injured, that can lead to gastroparesis, or delayed gastric emptying, in 10 to 15% of the cases. Dissection, especially within the hiatus to mobilize the esophagus, can lead to pneumothorax that has to be dealt with by a water-sealed drain. The dysphagia, poor gastric emptying, or gas bloat are the symptoms of fundoplication. Recurrent hernia, of course, as is true for any sort of a hernia, there is always a chance of recurrence. Recurrent hernia can occur. Fundoplication can slip within the esophagus, and in case you have done a mesh repair, there is a possibility of the mesh eroding within the esophagus. Yes, that's all I think.
Discussion on management of paraesophageal hernia. So anybody can ask any question. We are covering these topics from recent advance so that you have a ready-made reference for your theory paper. So anybody can ask any question, any query. The one important advance in management of these hernias are this minimal access surgery. The laparoscopic approach has been taken as a standard of care for management of all types of hiatus hernia.
Yes.
Okay.
Here, there is this particular picture shows that when you do this fundoplication, you should keep a bougie inside the esophagus, around 36-40 bougie, so that the repair doesn't become too tight. Because if the repair becomes too tight, these complications that we mentioned about post-operative, like dysphagia, gas bloats, become a very difficult things to handle. So ensure that this esophagus is not too much narrow during this repair.
And more so, people who are scared of this complication, they are more and more people going for two-pay fundoplication, which is a 270-degree wrap, where the chance of narrowing is less. If we two-pay fundoplication, 270-degree, then the chance is less and more and more. And nowadays, people are also going for anterior fundoplication. Dots.
Hello.
Yes.
আমি ডক্টর বসাক মাখনদা
yes
একটা কোশ্চেন আমার মনে হয় মাঝে মাঝে যে আমরা তো যখন এন্ডোস্কোপি করি বা আল্ট্রাসাউন্ড করি তখন আমরা দেখি যে স্মল হার্নিয়াস আর দেয়ার so actually which patient should be advised for surgery মানে we always come across there is small hernia small sliding of the esophagus is at G junction at 34 centimeter তো এই ধরনের কেসে কখন আমরা অ্যাকচুয়ালি পেশেন্টকে বলবো যে আপনি এবার অপারেশনটা করান সার্জনের কাছে যান
yes the point is the prime indication for any surgical intervention is failure of medical treatment. The primary treatment for sliding hiatus hernia is medical treatment. That means you give the patient some gut motility agents like liposulfuride or Maxeron and then PPI. If the patient responds, the main symptom is reflux. If the patient is controlled with these drugs, then surgery is not indicated because surgery has a lot of advantages plus some disadvantages. So the primary treatment is medical treatment. But if the patient is not compliant, he cannot take the medicines or he has reflux symptoms in spite of this medical therapy. And more so, patient having some changes in the lower esophagus in the form of Barrett's esophagus or patient has got peptic ulcer in the esophagus junction, they are the patient who are candidate for surgical intervention. But paraesophageal hernia is a different entity. Sliding hiatus hernia is one where you can manage this patient with this medical treatment. But paraesophageal hernia, where there is a hernia along the side of the esophagus, most of these patients require surgical treatment unless it is very small. Dr. Bhattacharjee?
Yes, but still there is a group which suggests that you should go for a selective approach. If the patient is asymptomatic, and you just detect a paraesophageal hernia, you can tell him that you have to be very watchful because your condition has got some the potentiality of developing serious complications. But you can still sort of postpone the hernia for the repair or surgery for some time. But when they are symptomatic, then that they must be treated by some form of surgery. Asymptomatic ones, you can still wait.
Thank you.
Okay. Okay then. Thank you all.
Okay. Thank you, sir. Thank you.
Thank you, Dr. Bhattacharjee.
Thank you.